And we move on to the next speaker, who is Dr. Vivek Singh. Dr. Vivek Singh has done his PhD from BHU, and he has done his postdoctoral fellowship from Cleveland Clinic Cole Eye Institute, and then he has been working at the LV Prasad Eye Institute in Hyderabad for the last, let us say, 8 to 10 years, and he is specializing in cornea and corneal wound healing, and we would be wanting to hear from him about how he is using various animal models for stem cell deficiency, limbal stem cell deficiency, developing corneal scar models and therapies, and using also 3D bioprinting for cornea. Dr. Singh.
Thank you. Thanks for nice introduction. As you told that I am working on corneal wound healing and also 3D printing of cornea, but today I will be talking about something different which relates to this conference, that is chronic diseases. And you all know that dry eye is a very common eye disease. So today I am talking about a dry eye model. Topic of my today's presentation is ocular surface health for dry eye disease and Stevens-Johnson syndrome in the Indian population through tear proteomics. Just to give you a glimpse of a dry eye, before that I want to tell you this is our eye, as you can see over here. The front portion, what you see over here, is called cornea. What you see, it's colorful because of the color of the iris, but actually it's a cornea which is very transparent. And above that is a layer of tears. So this is moving with. This is called the tear layer, which maintains the homeostasis of cornea, it prevents from infection, it lubricates the epithelium. That's very important to have a healthy ocular surface. And this is the tear. You can mouse is very slow. Yeah. The tears are basically the three layers: the mucin layer, the aqueous layer, and the lipid layer. The lipid layer is the outermost layer. If layer is affected in any way, due to the constituent of this layer, due to the informity of this layer, it leads to dry eye disease. It can be evaporative or it can be aqueous. Aqueous means when there is a less content of aqueous fluid in the tear film. That is because of any malfunction in the secretion of the tear fluid from the lacrimal secretion. And it can be due to the abnormality, also due to the formation of inform. The lipid layer is not very uniform because of the problem in the conjunctiva, you can see over there. So this has to be very lubricated to have a smooth eye. Otherwise, all of you have to use the eye drop or the tear drop to have a comfortable eye and eyelid movement. So we did one small study in our institute where we surveyed around 14 lakh patients. And what we found that out of them, around 22,000 patients have the dry eye disease. Among them, 21 shows the symptoms of dry eyes. One is they come with the presentation and we find that this much patients have the dry eye symptoms. Among them, there are around 4,000 which have the aqueous dry eye. Aqueous means the liquid of tear which is formed is less compared to the normal tear. Then 8,000 people have the mixed dry eye patient, and then 7 have evaporative, means the lipid layer is not informed. So tear is formed but it evaporates. Then again we have a dry eye condition. It leads to irritation, redness, all the pain in the eye. That's when the doctor advises you to use the tear drop or any artificial tear. So it has been shown that around 5 to 50% people have dry eye. A recent study in the US has shown that around 16.4 million people have dry eye disease. And our studies have shown that in India, by end of 2030, around 20 million people will have dry eye disease. So they have to go for the clinical management for their dry eye symptoms. It's a big number compared to the population. We published this paper last year in Ocular Surface. Today I am talking about one of the diseases, which is called Stevens-Johnson syndrome. It happens due to the adverse drug reaction, which also lead to a dry eye disease and different type of ocular sequelae. So this is, you can see this is called Stevens-Johnson syndrome, where you get lots of blisters. And then if you look for the other symptoms, you get a mouth ulcer, redness of conjunctiva, then there is a detachment of skin epithelium. The skin starts shedding off the epithelial layer. And it's mainly due to the adverse drug reaction, basically the sulfur drugs. So you can see that 6.84% of this is severe cutaneous adverse drug reaction that caused by this. Among them, around 3.92% is called SJS, 5.26% is called SGS10 and 28% called 10. So what is this SGS10 and SGS10? Basically it depends on the formation of blisters. If blisters are less than 10%, we call them SGS. If it is more than 30%, we call them 10. In between we call them SGS10. In SGS condition, patients mostly survive, but in case of the 10, most of the patients end up having a very complicated life, and the mortality rate is around more than 90%. It's very devastating disease, and most of the patients have very tough life, and their survival rate is very late, 4 to 5 years. It leads to the skin shedding, the ocular problem, the mouth problem, they have cervical infection, they have UTI infection. It leads to all infection, and slowly patients go to the ICU, and then so when we get the patient in our clinic also in LVPI, when they come with the ocular symptoms, when they the secondary stage of infection, what happened over there? There is a sequelae of that. Before that, you can know that this is a drug-induced disease. It's immune-mediated delayed hypersensitivity reaction. And it's a cutaneous and mucous membrane of the body where it is affected. So this is a normal eye how it looks like. Then slowly what you see is that this eyelid get keratinization. Then you get a scarring of the cornea. Scarring means there is a fibrosis in the cornea, which affects our vision. This can lead to the final visual impairment. Visual impairment means loss of eyesight in the layman's style. And then you get lots of vascularization, and as well as there's lots of scarring in the cornea, you can see over there. And right now there is no treatment for SGS. It's only the management. If you can manage it well, patient survives well for longer time, but there is no real treatment. Only what doctors do is they keep you away from the drug which has caused you this allergy, this SGS. They stop your drug and then they give you steroid. You all know what are the side effects of steroid. So the best treatment all over the world they are trying to know is if you can detect somehow in the serum or using some biomarkers that this patient is allergic to the drug, that patient should not be given drug. Hope in future Human Genome Project will help you out, that we have the data of all the individualized person and look for different drugs which they may have allergic to, and we should not prescribe them in future when they come to clinic for any such diseases. So most of the studies for SGS has been done in Japan and the US group. US group is from the Harvard, those group who are our collaborators also. So what they have shown that in this study in Japan, they have shown that there is a high expression of granulolysin, which is one of the factors causing lesions in the skin, and which is also due to the high expression of NK cell and the CTL cells. In this study in Japan, done in SGS patient and also in the adverse drug reaction cases, and they found that there is also high expression of granulolysin. So this has been shown to have the main factor causing the SGS10 factors. Then there is some study in Taiwan where they have shown that interleukin 15, similarly interleukin 13, 15 have also play a role in the symptoms of SGS10. They are really highly expressed in the serum what they have found in their studies. Then there is one more hypothesis where they have shown that most of this disease is because of the intermediate of vitamin A, that is retinoid. When there is this disease, there is an increase in this retinoid metabolism. It goes to the liver and circulation, finally lead to the skin lesions and all the symptoms of this disease which you can see over there. In some of the experimental model, even the Shankar Nathara, one of the biggest eye hospital in India, they have shown that in the Indian population also they have seen high expression of IL-15, IL-17A, but however there is a decrease in the expression of IP-10. Similar study was shown by the Japanese group also, where they have shown the similar result where the IP-10 was downregulated, whereas IL-8 and granulolysin was upregulated. So these are the factors which people look for to make sure that there is a symptoms as sequelae of SGS10 in a patient. So we also started looking for in our patient what we come to the IL33 Institute. So we did one pulse study where we took samples from around 24 eyes and we did a multiplex ELISA and we looked for different cytokines. And what we found that there was high expression of IL-8 and there was a decrease in the expression of CXCL4. Both are this is a chemokine, and they play a vital role in the angiogenesis, which may lead to the fibrosis as well as also in the vascularization of the corneal ocular surface. So we confirm that okay, our data and sampling is perfectly fine. As you can see over there, we also look for other cytokines, which you can see that IL1, IL2, IL6, which were upregulated, and our data was similar to the other groups from all over the world, from India as well as the Japanese group, and there was a low expression of CX10, as you can see over there, which was mimicking the data shown by other groups. So okay, so this data confirm that our process is perfect, our methodology is perfect. So okay, so we thought let's go into deep and let's look for our Indian patients, how they perform when they have SGS-10. So we started collecting the tears from our patients which come to our clinic, both in the acute case and the chronic cases. And we did the whole tear proteomics. Then we run the tear drop and we did the orbit trap, and then we did analysis of whole tear protein analysis, and then we also validated our data using the real-time PCR as well as the multiplex ELISA and also the visual ELISA. And these are our exclusion criteria. We make sure that we are not taking the patient which have HIV, AIDS or pregnant, because this can also affect the serum constituent of cytokines and chemokines. We excluded those patients. So what we found in our whole tear proteomics analysis is that around 1700 protein were expressed in the tear of patient and control. Out of that, 41 were uniquely expressed in the patient, which were not present in the control group. And 5 protein were uniquely present in the control group. Among them, you can see that 250 proteins were highly expressed in SGS patient and 220 proteins were down-regulated in the SGS patient. So these were around 470 proteins which were differently expressed in SGS versus the control tear group. So these proteins might be playing a role in the disease manifestation and the final sequelae of any condition. So we then look for different parameters and different signaling pathway using different bioinformatics software. What we found that neutrophil, elastase, ubiquitin, protein 800, S100, neutrophil, these are the main signaling pathway proteins which were upregulated in the SGS patient tear compared to the normal tear. And what we hypothesized that neutrophil, the necrosis, or what we call necrosis, is also a type of apoptosis of the neutrophils. So this may be one of the factors which may be causing the lesions in the skin of the patient having the SGS-10 after adverse drug reaction. So we check for that. We taken the sample, eyelid sample, and the sample from ocular surface of this SGS patient, and we look for this MPO, which is the marker of neutrophil, along with CD11B. And you can see they were highly expressed in this patient of SGS-10. And we also saw that there is a high expression of IL8 in SGS patient compared to the control group. So these factors were confirmed that this might be playing a big role, and neutrophil necrosis may be one of the factors of causing the lesions in this SGS patient. And it may also lead to the scar in the future. And this is again the IP analysis. I will not go deep into that. This again says that when you look for all the tear proteomics, there are lots of signaling pathways we can see in this patient. Among them IL8 signatures, leukocyte, HIF, that is, and ROS dependent pathways were highly regulated in SGS patient. So we look for one of the more important things which leads to corneal scarring. As I have shown in the beginning that in this SGS patient that leads to corneal scarring, which leads to the visual impairment. So why this scar happens? What is the cause behind the scarring? So in normal conditions, you can see that this clustering is one of the saffron, which is bind to the pro-MMPs. MMP is metallic metalloprotein. So when they are bind together, MMPs are not free. So there is a homeostasis and they don't lead to any abnormal remodeling. But in what happens in SGS patient, clustering level goes down. Then your pro-MMPs are free, and then they become activated MMPs, and then they start remodeling. They start digesting the collagenase, and then you get scarring and all fibrosis. So this is one of the factors where there is high expression of MMPs in SGS because of the low level of pro-clustering. So we check that again in our mass spec data along with the ELISA, and we want to find that there is a high expression of, the low expression of clustering in this SGS patient compared to the control. That due to that there is a high expression of MMP9. So MMP9 metallic metalloprotein activity goes up, which lead to the corneal scarring. Same was also validated in more 40% using the ELISA, and same data was confirmed, which was we got in our proteomics data. Then you can see there are lots of dots over here. So don't worry about the dots. These are just showing the expression level of 50 various tier proteins. So we look for them. Then what we found is that 50 proteins which has to be there in normal tier were not present in the SGS patient. Some of them is like lactoferrin, opinephrine, lysozyme, lipocalin. These were the proteins which has to be for the normal function of any tier, which also have the antibacterial effect. So they were not present in this SGS patient, which also lead to the ocular infection. These are the factors which prevent any infection in the eye. You can see these all were down regulated in SGS patient compared to the control tiers. So along with that, we also find one of the unique protein which was only expressed in the patient. We look for all the 41 unique proteins which were expressed only in the SGS, not in the clinic. Among them, most of them were commonly found one thing called IL33. It is a IL-1 family member and it is involved in the keratinocyte inflammatory response. So this is our new finding which we have found that IL-36 is highly expressed. Then we also check in the eyelid ocular surface by using the IF immunostaining marker, and we find that they are highly expressed in the eyelid also. So we also then check in the ELISA and we find that this is highly expressed in the patient serum as well as in tear, IL-36. And then we look for literature. There was no literature available. I am done. So there was not much literature available for this IL-36 gamma in any SGS or 10% or any ocular thing. But we have found some, this is linked to some of the systemic inflammatory disease in the other disease, not in the ocular disease. In future, we might think of having this as a pregnancy kit, where we can put a tear drop and then look for this IL-36 presence absence, which can give us idea, okay, this patient may be resistance or have some reaction to any drug, and that can prevent the SGS to occur in this patient. Then we also look for the eyelid. As you can see over there, there is a keratinocyte of eyelid. So this is eyelid. This we call the conjunctival eyelid. And you can say this is a SGS patient where there is a ocular inflammation and there is a keratinocyte of the eyelid. So as I talked to you about earlier, you can see that there is a keratinization of lid margin in SGS patient compared to control. There was no keratinization. However, you can see there is keratinization that can be seen by the marker of CK, cytokeratin 1, cytokeratin 2. We also quantify that has been shown that there is a high expression of this keratin in the SGS patient. Similarly, there was high expression of flagellin and trans-glutaminase protein in the lid margin of SGS compared to the control. And then you can see there is a high expression of CK19 and MYC5 in the SGS patient. All this shows that there is a vascularization and the normal function of eyelid is affected in SGS patient, which may lead to all the inflammation and as well as the infection of the eye. I'll skip this slide. So we check for different factors which can lead to keratinocyte deregulation in this patient. And you can see there is high expression of KGF, FBGF, elongation growth factor, TGF-A, TGF-TNF-A and TGF-beta. These all were highly expressed in this SGS patient, both in the eyelid tissue. This is RT-PCR data from the eyelid tissue. It all shows that there is a high expression of this protein which may be playing a role in the infection and the angiogenesis of this tissue. Just to conclude that IL-8 should be one of the primary factors which may be causing the neutrophil degranulation or netosis in the SGS ocular surface. There is a significant downregulation of lacrimal gland secretion, like I told you, lactoferrin and so on has observed to be really less expressed, and that may lead to the reduced pain and inflammation. If you can treat somehow and supplement that factors, we can reduce the pain in the eye in a dry eye condition. And we found that IL-36 gamma might be one of the factors causing the keratinocyte inflammatory response. So if we can treat this, that can also prevent the keratinocyte inflammatory response. It can be mimicked or can be minimized. In short, a possible source of keratinization of lid margin conjunctiva in SGS might be the adjacent lid margin epidermis. Start from the lid margin, you can see over there, it can lead to the whole corneal infection and the ocular inflammation occurs and then scarring occurs, which can finally cause the visual impairment. That all can be prevented if you can have a better immunotherapy for this patient using all these chemokines and cytokines. So people are trying to use different drugs to treat these factors like supplement IL-17, IL37, IL8, but not in the eye disease. They are trying in other cancerous disease. So I don't know in future if you guys can help us to find some of these, then the pharmaceutical, some drug which can be used from the natural sources from India, which can be treat this condition. That will be great. So thank you very much. So this is my team from Prasad. This all work was done by Madhuri, who is my PhD student, and she is going to submit a thesis in next month. The whole work was done by her, and this is my team. And this is Dr. Sayan Basu, who is a clinical partner who helped in getting the samples from the patient. And thanks to our institute, Talipur Institute, and also I want to thank CCMB and IT Hyderabad as they are our collaborators in this work. And thanks to my funding agency, SERV, DST, DBT, for supporting our lab. Thank you. I am open for any question.
Thank you, Dr. Vivek, for enlightening talk on ear and lacrimal secretions. So I'm sure that people will be having some or the other questions about your work. So it's open for everybody to ask some questions. So,
Good morning, sir. Sir, you shown that the neutrophil degranulation is one of the causing factor of these symptoms. So, and this neutrophil degranulation is also associated with some chronic disease, pulmonary disease, and asthma also. So, does the dry patient also have the association of that kind of disease?
Generally, in any immune disorder, we get this dry condition. So, person who is having any allergic reaction or HIV, they all also get to lead to dry disease. But there is no direct connection, so I can't answer that question right now.
Thank you, sir.
I have a question.
Yes.
How did you take that vigilance against the symptoms? Like, did you take the eye out of those ILC?
So what happened when I got it. What happened in this patient when there is a ocular infection, we do amniotic transplant in this patient. So before that we take out some tissue and then put a amniotic transplant, which help in the recovery of this eyelid. So those biopsy we take and do the RNA analysis or doing the immunochemistry. I thought you have some question.
No. I was wanting to start something. So you said that IL33 can be a good marker.
Yes.
For that
Early prognosis of the disease.
So have you been able to use it in patients and see whether something like that is happening?
So we saw in the blood serum and tears that it's highly expressed.
No, but in
Not-
patients,
no, it will
you have
take-
not been able to do
No,
it because you have a lot of patients, patient falling in your clinic.
But we have to, yeah, that's true. We are not started yet, we are in the plan of that. It will take at least 5 to 6 years.
Okay.
To our approval process.
Okay.
Currently we are using the stem cell therapy, that we have got approval.
Okay.
We are not talking about that, but we are doing stem cell based therapy for this disease also.
Wonderful. Wonderful.
Just a concern, when you have taken the care of tears, but it can be the cause and effect, right? It can be the just
Yes.
effect. It has nothing to do with the cause.
Yes.
Just can you please comment?
So yesterday I was sitting there with Professor Singh, who is sitting over there, one of the immunologists, and he said that there can be multiple factors in these diseases where there is a adverse drug reaction. That IL8 expression, suppose take an example, it attracts the neutrophils, but IL8 can also come from the injured cells. So if IL8 goes up, neutrophil goes up, it may lead to a neutrophil necrosis. But the cause in fact is always a tough question to answer. It's like a hen and egg, which comes first. So still we are trying to find out what is the factor, but what we mimic that IL8 can be one of the factors which may be recruiting the neutrophils over there and causing the lesions in the skin. If I am correct, or you want to have some other?
Yeah, that's what I feel. See, because it is a disease patient, already he is affected with the dry eye or whatever it is. and it is externally secreted secretion is the tear, right? My logic is perhaps even if it like if you were to figure it out, maybe if something else, I don't know, I'm not related to the so maybe I feel this is the effect. Perhaps this can happen in many kinds of secretions of the deceased parent. So one way is perhaps if there is any other secretion other than the dry eye, and if you try to see if in both the cases, if this IL8 or whatever this guy is, then it is a simple way of confirming, because before going and making a lot of work, it is important to rule out that possibility. Just if you see, if it matches with any other thing IL8, perhaps this can be, logically, we can figure it out whether it is.
I got the point.
Yeah.
You are right. So for that, what we are doing is we are using both Hadley control, the acute stage and the chronic stage. So we have to compare all these three stages in bigger population. Then only we can come to the final conclusion. So this is our preliminary data where we are just predicting.
So did you get to characterize the neutrophil? Are they immature neutrophils or mature? Because the early responders are the different profile than the late.
So we still, this is our just preliminary data where we got this. So last month only we got this data. So I have to still go into deep to know that which type of cells are there and how they are going to perform.
So then there will be a therapeutic window maybe there. We can capture that.
I will look into that. I will look into that. Still I have no answer for that.
Thank you.
Thanks.
One quick question.
Does screen time associated with dry eyes?
Sorry?
Screen time. Nowadays we watch too much laptop, iPhone.
It has been shown that if you have more screen time, more than 8 hours, 7 hours, it is effective.
Okay. And also like metabolic syndrome?
Any allergic disease in the body can lead to dry eye disease. Again, can lead to dry eye disease. Again, it depends on your other activities in the day. How you perform, how you exercise, what you drink, what you take. All is together, taken together, can affect dry eye condition. But there is no treatment for dry eyes. So if you get dry eye, don't worry, take a tear drop.
Okay.
Only the problem is tear drop is costly, you have to take throughout your life. So people are trying to have some biological thing like a serum, something which can treat this dry eye condition. Otherwise, just take a tear drop. It's not very costly, but you have to take throughout your life. Or you will have pain, irritation, all itching and all this happens in the condition.
Okay, thank you.
Thank you.
Thank you, Dr. Vivek. It was a very nice talk. And incidentally, I also have this allergy to sulfur. Those people being allergic to sulfur.